The focus of this presentation will be the anterior cervical triangle. The neck serves as a conduit for the transmission of numerous structures from the head to the thorax and vice versa. Superiorly, the neck is bound by the external occipital protuberance, the mastoid process, which again is that bump behind the ear, and the mandible, shown here. Inferiorly, the neck is bound by the clavicles, the jugular notch of the manubrium, the acromion of the scapula laterally, as well as the C7 vertebral body. There are numerous palpable landmarks and structures in the neck, from the carotid artery pulse to the submandibular glands to the cartilages of the larynx. Eventually, we'll talk more about the palpable soft tissue structures, but for now, let's focus our attention on the palpable hard tissue structures. Perhaps the most notable prominence in the neck is the Adam's apple, shown here. This is referred to as the laryngeal prominence. The laryngeal prominence is a forward-facing projection of the thyroid cartilage, and it is much larger in males than it is in females. Just above the thyroid cartilage is the hyoid bone, as shown here. This is also palpable in the upper reaches of the neck. We'll discuss this bone in great detail in just a moment. Below the thyroid cartilage is the cricoid cartilage, as shown here. This cartilage is smaller than the thyroid cartilage, but is also palpable. Between both the thyroid and cricoid cartilage is an important membrane which we'll discuss in a moment, which will allow emergency physicians to gain quick access to the airway. Below the cricoid cartilage are a number of rings which we refer to as the tracheal rings. Notice that the upper edge of the thyroid cartilage sits roughly at the level of C4. This is an important landmark because there's also other transitions that occur at this level. For example, the level of C4 is also where the common carotid artery bifurcates into the internal and external carotid arteries. Now let's discuss each of these hard tissue landmarks individually. The hyoid bone is very unique because it is a floating bone. In other words, it makes no articulation with any other bone in the body. The hyoid bone is suspended in the upper neck by both ligaments and muscles. This U-shaped bone is comprised of three different parts. It has an anterior-facing body, a lesser horn which projects from the body, and a much larger, greater horn, as shown here. These horns are the sites of attachment for both ligaments and muscles. Let's take the lesser horn as an example first. Notice here the lesser horn is projecting from the body, and extending from it is the stylohyoid ligament, which extends from the styloid process at the base of the skull all the way down to the lesser horn of the hyoid bone. In general, the hyoid bone is an important component of the swallowing apparatus, so you'll notice that it is highly mobile during the swallowing process. The hyoid can function as a prop, helping to keep the upper airway open. In just a moment, we'll revisit how all of these muscles attach to the hyoid bone. But for now, let's take a close look at the relationship between the hyoid bone and the thyroid cartilage. When considering the hyoid bone in relationship to the structures of the larynx, it is firmly secured below to the thyroid cartilage via a membrane referred to as the thyrohyoid membrane. Notice there's a small slit in this membrane, shown here, which allows for an important neurovascular bundle to supply the inner larynx. We'll talk more about the structures passing through this opening in a moment. At the anterior edge of the thyrohyoid membrane, there is a thickening of the membrane, which is referred to as the median thyrohyoid ligament. The morphology of the thyroid cartilage is shield-shaped, which you can begin to appreciate here. Recognize that the posterior aspect of the thyroid cartilage is open. In other words, it does not form a complete ring of cartilage. The opening is going to allow for communication with the pharynx. So these lines that I've just drawn in represent the inferior pharyngeal constrictor muscle coming to attach on the oblique line of the thyroid cartilage. This area is referred to as the laryngopharynx, and it's the transition point between the pharynx and the esophagus. Also appreciate that the thyroid cartilage has associated with it a superior and inferior horn. Here's the superior horn, and here's the inferior horn. Recognize that the inferior horn of the thyroid cartilage is attached to the cricoid cartilage here at the cricothyroid joint. Unlike the thyroid cartilage, the cricoid cartilage is in fact a complete ring of bone. In fact, it has a signet ring shape to it, meaning that it looks like a ring a king would wear on his finger, with the slender portion of the ring facing anteriorly, and the signet portion of the ring, which would carry the jewel, would be here facing posteriorly. Spanning between the cricoid cartilage below and the thyroid cartilage above is the very important cricothyroid membrane, which is a palpable landmark used by emergency physicians to gain immediate access to the airway. If the airway becomes obstructed as a result of a foreign body or the result of swelling, like in the case of a laryngeal spasm, emergency access can be gained through the cricothyroid membrane, which is referred to as a cricothyrotomy. In order to perform a cricothyrotomy, an emergency physician will first palpate the laryngeal prominence, shown here. They will slide down the slope of the anterior edge of the thyroid cartilage, and then they'll find themselves in a small valley. That valley represents the area of the cricothyroid membrane. After finding themselves in the valley, they'll come upon another little hill, which represents the cricoid cartilage. Once these landmarks are identified, the physician will use a 10-blade scalpel in order to incise the skin above the cricothyroid membrane and to incise the cricothyroid membrane itself. Once this puncture incision has been made, then access can be gained to the airway by placing an endotracheal tube in the trachea. What is important to recognize is that the vocal folds are positioned just above the cricothyroid membrane. So in the area I'm drawing in red, this represents where the vocal folds would sit. These folds are the vocal cords, and recognize they can adduct, in other words, they can come closer to the midline and can close upon themselves. Let's do a quick demonstration. Hold your breath and then open your mouth while still holding your breath. Recognize that opening your mouth has nothing to do with your ability to hold your breath. Why is that? Well, that's because the vocal folds are closing. So if we look at the larynx from a superior view, this would represent the vocal folds in an open state. And now if we look at it in a closed state, here are the vocal folds closed. So in the instance of a laryngeal spasm, for example, the patient has no control over the closing of these vocal folds. They become so swollen that they have closed off the airway. And so it makes sense that we can gain access to the airway immediately below the level of the vocal folds here at the cricothyroid membrane. This not only is very safe, but it's very easy access. The reason this area is safe is because overlying this area and underneath the skin, there are just very few cutaneous vessels, specifically the anterior jugular veins, which are relatively small. And so the risk of incising those veins is minimal. For longer-term airway management, the preference is to perform a tracheostomy. A tracheostomy is a surgical procedure performed through the anterior tracheal wall, just inferior to the thyroid isthmus. So here we note the area of the thyroid gland. Here's one of the lobes, here's a second lobe, and this portion is the isthmus of the thyroid gland. In order to perform a tracheostomy, an incision below the thyroid gland through the between the tracheal rings is made and an endotracheal tube is placed. The isthmus of the thyroid gland typically lies over about the second or third tracheal ring. Therefore, the incision which is made for a tracheostomy is usually performed between about the fourth and fifth tracheal rings. How is the neck organized? Well, the neck is organized into three different layers. The superficialmost layer represents the skin, which of course envelops the entirety of the neck. The second layer down is referred to as the superficial cervical fascia. It is within this layer that we have variable amounts of fat, in addition to the platysma muscle, which is a muscle of facial expression. Also within this layer are superficial veins, such as the anterior jugular veins, as well as cutaneous nerves, such as the transverse cervical nerve, which we saw previously originating from Erb's point. The deep neck, however, is divided into cylindrical compartments which are surrounded by deep cervical fascia. Here in this transsectional view, we can better appreciate how these various layers of cylindrical fascia help to organize various compartments of the neck. The layer of fascia, which is outlined in red, is referred to as the superficial layer of the deep cervical fascia. It's also known as the investing fascia. This cylindrical layer lies just deep to the superficial cervical fascia, and it's going to help form the roof of both the anterior and the posterior cervical triangles. In addition, notice how this particular fascial layer will invest two different muscles. It will invest the sternocleidomastoid muscle, shown here bilaterally and anteriorly, and this fascial layer will also invest the trapezius muscle bilaterally. Shown here in light blue is the pretracheal fascia. This layer lies just anterior to both the respiratory and digestive tracts. This particular layer is going to enclose the thyroid gland, and it's going to fuse on either side with part of the carotid sheath, which you see here in this turquoise color. Contained within the carotid sheath are three different structures. First and foremost, we have the internal jugular vein. We also have the common carotid artery and the very important vagus nerve, cranial nerve number 10. This carotid sheath runs from the base of the skull all the way down to the root of the neck. Shown here in lime green is the buccopharyngeal fascia, which is sometimes described as the posterior aspect of the pretracheal fascia. The buccopharyngeal fascia encloses the pharyngeal constrictor muscles, and it continues forward onto the buccal muscles, which are the deep muscles of the cheek. And lastly, the deep cervical spine, along with its associated musculature, is enclosed by the prevertebral fascial layer. This layer is shown here in gold. If you're wondering why you need to know these fascial planes, the answer is that they have clinical significance surrounding the route and spread of infections. Let's take the anterior cervical space as an example. This space is situated between the pretracheal fascia, shown in the light blue, and the fascia of the strap muscles, which is shown here in purple. So all this area, represented by the checkered pattern, represents the anterior cervical space. Recognize that if for some reason you have an infection here in the neck within this space, that infection can spread inferiorly into not only the superior mediastinum, but also into the anterior mediastinum of the thorax. Now let's suppose that you had a molar tooth abstracted, and after that abstraction, an abscess formed. Interestingly, the bacteria from that abscess could find their way into a space called the retropharyngeal space, which is encircled here by the black box. The retropharyngeal space is situated between the buccopharyngeal fascia in light green and the prevertebral layer of deep cervical fascia in gold. If bacteria from that abscess entered this space, it could transmit itself south all the way down to the posterior mediastinum. In addition, there is a third space known as the danger space, as shown here. This space lives between the layers of the prevertebral fascia, and it provides a route of spread for infection from the base of the skull all the way down to the respiratory diaphragm. The remainder of this video will focus on the structures of the anterior cervical triangle. In this image, the anterior cervical triangle is shaded in light blue. Previously, we have discussed the posterior cervical triangle, which is shaded here in green. Superiorly, the anterior cervical triangle is bound by the mandible. Laterally, it is bound by the sternocleidomastoid muscle, specifically the anterior edge of that muscle. And then thirdly, it is bound by the midline of the neck, as shown here. The roof of this triangle is made up of that investing layer of deep cervical fascia, which was outlined in red in a previous slide. Notice how the anterior cervical triangle is further divided into 4 smaller triangles. For example, there is the carotid triangle. This is where the common carotid artery will course. There is also the muscular triangle, which contains the strap muscles in the neck and the anterior neck. There's also the submental triangle just below the chin. And lastly, the submandibular triangle, where the submandibular gland is housed. For the purposes of this block, I'm not going to hold you responsible for knowing the exact boundaries of each of these smaller triangles, but do know the boundaries of the larger anterior cervical triangle. This image demonstrates very nicely the various components of the superficial cervical fascia. For example, here's the platysma muscle. This muscle is a muscle of facial expression because it is innervated by the facial nerve, cranial nerve number 7. When this muscle is contracted, it will tense the skin of the neck. Also within the superficial cervical fascia are a number of cutaneous veins. For example, here are the anterior jugular veins. Notice how these veins run longitudinally along the length of the neck, just lateral to the midline. During a cricothyrotomy procedure, as long as the incision is made within the midline, these anterior jugular veins are often spared. These anterior jugular veins begin in the submental region, which is the area just beneath the chin, and they descend along the length of the neck to drain into the external jugular veins. Notice how this jugular venous arch connects the left and the right anterior jugular veins. This arch is at risk during a tracheostomy procedure, for example. And as was mentioned previously, the superficial cervical fascia also contains cutaneous nerves, like the transverse cervical nerve shown here, originating from Erb's point. Now let's focus on the suprahyoid muscles. These suprahyoid muscles are responsible for suspending the hyoid bone. In addition, they will help to raise the hyoid during swallowing and during tone production. 2 of the 4 suprahyoid muscles will also constitute the floor of the oral cavity. Let's look first at the digastric muscle. This muscle has an intermediate tendon which slips through a sling attached to the hyoid bone. The tendon divides the muscle into a posterior belly and an anterior belly. The posterior belly of the digastric attaches from the mastoid process, shown here, to the hyoid bone. This particular belly is innervated by cranial nerve number 7. The anterior belly, however, is going to attach from the mandible to the hyoid bone, and it happens to be innervated by a different nerve. It is innervated by the nerve to the mylohyoid muscle, which is a branch of V3, the mandibular division of the trigeminal nerve. Immediately anterior to the posterior belly of the digastric lies the stylohyoid muscle, shown here. Notice how the stylohyoid muscle splits and allows the tendon of the digastric to slip right through it. The stylohyoid muscle, along with the posterior belly of the digastric muscle, are both derived from the second pharyngeal arch. As such, they have the same innervation and are both innervated by cranial nerve number 7, the facial nerve. The stylohyoid muscle, as its name suggests, runs from the styloid process of the temporal bone down to the hyoid bone, specifically attaching onto the greater horn of the hyoid. The stylohyoid ligament, which was mentioned previously, runs in very close proximity to the stylohyoid muscle. The next 2 muscles, the mylohyoid, shown here, and the geniohyoid, both constitute the floor of the oral cavity. In the right-hand image, we are standing within the oral cavity looking down at the floor. The mylohyoid muscles, one on each side, will join in the midline at the mylohyoid raphe. This particular raphe is not visible in either of these images, but you can see an example of this in a subsequent slide. The mylohyoid muscle originates from the mylohyoid line on the back surface of the mandible, as shown here, And again, these muscles will unite in the midline at the mylohyoid raphe. This muscle is going to be served by the mylohyoid nerve, which again is a branch of V3, the mandibular division of the trigeminal nerve. Along with the mylohyoid muscle, the geniohyoid will also constitute the floor of the oral cavity, and it will help to raise the hyoid bone during swallowing. The geniohyoid muscle originates from the inferior mental spines on the back side of the chin, and from those mental spines, the muscle courses to the body of the hyoid bone, as shown here. From this internal view of the mandible, we can now appreciate where 3 of the 4 suprahyoid muscles attach. For example, here's the mylohyoid line for the attachment of the mylohyoid muscle. This area represents the inferior mental spine for the attachment of the geniohyoid muscle. And on the undersurface or the lower edge of the mandible here at the chin is a roughened area for the attachment of the anterior belly of the digastric muscle. Now let's turn our attention to the muscles that live below the hyoid bone. These muscles are collectively referred to as the infrahyoid muscles. These muscles are easy to name as long as you remember to name them from the bottom up. Collectively, these 4 muscles are responsible for anchoring the hyoid bone, and in addition, they will depress both the hyoid and the larynx during swallowing and speaking. All of these muscles, with the exception of the thyrohyoid muscle, are innervated by the ansa cervicalis. More on that in just a moment. Let's begin with the sternohyoid muscle shown here. The sternohyoid, again, is named from the bottom up. It begins here at the sternum, specifically at the manubrium, and it attaches to the body of the hyoid bone above, hence its name, sternohyoid. Next is the sternothyroid muscle. Again, it originates from the sternum, specifically the manubrium of the sternum, the back side of the manubrium, and it attaches to the oblique line of the thyroid cartilage, shown here. The thyrohyoid muscle, just above the sternothyroid muscle, courses from the oblique line of the thyroid cartilage up to the hyoid bone. Again, this is the thyrohyoid muscle. And lastly is the omohyoid muscle. It, like the digastric, has 2 separate bellies. It has a superior and inferior belly, separated by a tendon. The word omo refers to shoulder, so the omohyoid muscle attaches from the scapula, specifically in the area right next to the suprascapular notch, all the way up to the hyoid bone, shown here. All of these muscles are innervated by a loop of nerve fibers referred to as the ansa cervicalis. The ansa cervicalis is formed by the ventral rami of C1, C2, and C3. These ventral rami are referred to as the cervical nerve plexus. This cervical nerve plexus provides motor innervation to the infrahyoid muscles by way of 2 routes, by way of a superior root comprised of C1 and an inferior root which receives contributions from both C2 and C3. C1 of the ansa cervicalis is said to hitchhike along the hypoglossal nerve, as shown here. In the image to the left, here's the hypoglossal nerve, and here's C1 hitchhiking along that hypoglossal nerve, giving off the superior root. Notice how the superior root of the ansa cervicalis lies on top of the carotid sheath, whereas the inferior root, derived from C2 and C3, course from behind the internal jugular vein, as shown here. And it meets up with the superior root to form a loop. And again, branches from this ansa cervicalis will serve the infrahyoid muscles. Here are branches going to the omohyoid muscle, for example, and here's one going to the sternohyoid muscle. Do note that the thyrohyoid muscle, shown here, does not receive its innervation from branches of the ansa cervicalis directly. Instead, it receives its innervation from a branch of the hypoglossal nerve, which is referred to as the nerve to the thyroid muscle. The nerve to the thyrohyoid muscle. Now I want to be very clear. This is not a true branch of the hypoglossal nerve. Instead, what's happening is those C1 fibers are continuing to hitchhike along the hypoglossal nerve until the C1 fibers give off the nerve to the thyrohyoid. This is a very important distinction because this muscle, the thyrohyoid muscle, is innervated by C1. It is not innervated by cranial nerve number 12, the hypoglossal nerve. Fibers from C1 simply hitchhike along the hypoglossal nerve before they're given off to innervate their target tissues. Running longitudinally within the neck is the common carotid artery, which bifurcates into the internal and external carotid arteries. Notice how the bifurcation of the common carotid artery occurs here at about the level of C4. This is also about the same level as the top edge of the thyroid cartilage. So you can use that landmark to help you figure out where the carotid sinus will be. Specifically, the carotid sinus is an enlargement of the very proximal portion of the internal carotid artery, as shown here. This dilation of the internal carotid artery is where a number of baroreceptors are housed. These baroreceptors are innervated by cranial nerve number 9, the glossopharyngeal nerve, and those baroreceptors are responsible for monitoring changes in arterial blood pressure. And here, seated in the nook of the bifurcation, is something referred to as the carotid body. Notice it is also innervated by the glossopharyngeal nerve, cranial nerve number 9. Unlike the carotid sinus, which contains baroreceptors, the carotid body contains chemoreceptors. These chemoreceptors sense changes in arterial oxygen and carbon dioxide. Recognize that the common carotid artery is both a high volume and high flow vessel. As blood reaches the bifurcation, it becomes more and more turbulent. And areas of turbulence happen to be prime sites for plaque formation. If an atherosclerotic plaque develops, it can significantly decrease the size of the lumen, thereby decreasing the blood flow through the vessel. In addition, if a piece of the plaque breaks off, it can literally travel to the brain to cause a stroke. Older patients are often monitored for plaque buildup in their carotid arteries. This can be done through a Doppler. If significant plaque formation has been identified, then a carotid endarterectomy can be performed, which is a surgical removal of the plaque. Carotid endarterectomies are usually performed secondary to carotid angioplasties. In both procedures, whether carotid angioplasty or carotid endarterectomy, stroke prevention is the goal. At about the level of C4, which is indicated here by the upper edge of the thyroid cartilage, the common carotid artery, indicated by the X, bifurcates into the external carotid artery, indicated by the circle, and the internal carotid artery, indicated by the triangle. Note that the internal carotid artery has no extracranial branches in either the neck or the face. However, the external carotid artery, shown here, has 8 different branches supplying structures of the neck and the face. Let's walk through all these branches. The first artery to arise from the external carotid artery is the superior thyroid artery. Notice its origin is roughly at the level of the superior horn of the thyroid cartilage. The superior thyroid artery courses inferiorly within the neck in order to supply the superior lobes of the thyroid gland. Near its origin, the superior thyroid artery gives off a small branch referred to as the superior laryngeal artery. This superior laryngeal artery will course in company with the internal laryngeal nerve in order to supply the inner larynx. The next vessel to arise anteriorly from the external carotid artery is the lingual artery, shown here. The lingual artery originates at the level of the greater horn of the hyoid bone. Here's the tip of the greater horn indicated here. As its name suggests, the lingual artery will supply the muscles of the tongue and the oral cavity. Arising immediately above the lingual artery is the facial artery, shown here. The facial artery quickly courses through the substance of the submandibular gland, and then it emerges onto the mandible in order to supply the muscles of the lower face. On occasion, recognize that both the facial artery and lingual artery can share a common trunk. This isn't common, but it can happen. Arising from the posterior aspect of the external carotid artery, near the origin of the superior thyroid artery, is the ascending pharyngeal artery, shown here. This artery will supply the muscles of the pharynx. Arising posteriorly at approximately the same level as the facial artery is the occipital artery. This artery will course to the occiput to supply the skin of the posterior scalp. A branch of the occipital artery will also supply the sternocleidomastoid muscle. We'll see a better image of this in just a moment. In the area of the ramus of the mandible, a small artery referred to as the posterior auricular artery is given off from the posterior aspect of the external carotid. This small artery supplies the area behind the ear over top of the mastoid process. And lastly, the external carotid artery is said to terminate as both the superficial temporal artery, shown here, which supplies the area over the temple and the muscles of the upper face, and it also terminates as the maxillary artery. So where the external carotid artery bifurcates into superficial temporal and maxillary is where it ends. The maxillary artery will enter into the infratemporal fossa to supply the deep face. In the dissection of the neck, the four main arteries that you will be on the lookout for will be the superior thyroid artery and its small branch, the superior laryngeal artery, along with the lingual artery and the facial artery. I would like to use this slide to emphasize a number of key relationships between these arteries and their neighboring structures. Here again is the superior thyroid artery originating from the anterior portion of the external carotid artery. The superior thyroid artery runs in very close proximity to a nerve called the external laryngeal nerve, which is going to innervate the cricothyroid muscle, which is an intrinsic muscle of the larynx, which jumps from the cricoid cartilage up to the thyroid cartilage. During a thyroidectomy, for example, a surgeon will need to ligate the superior thyroid artery. However, they want to be careful to preserve the external laryngeal nerve. If the external laryngeal nerve is compromised, a patient can present with a monotone voice. This is because the cricothyroid muscle pulls on the thyroid cartilage above, thereby placing tension on the vocal folds. This excess tension is what allows singers to hit the high note. Denervation of the cricothyroid muscle as a result of compromise to the external laryngeal nerve can therefore make it really challenging for individuals to fluctuate the pitch of their voice. As such, they present with a monotone voice. Next, notice the close relationship between the superior thyroid artery and the internal laryngeal nerve, as shown here. This artery-nerve pair enters into the larynx via that opening in the thyrohyoid membrane. Just above is the lingual artery at the level of the greater horn of the hyoid bone. This artery runs in close approximation to the hypoglossal nerve, cranial nerve number 12. The lingual artery will pass deep to the stylohyoid muscle as well as the posterior belly of the digastric muscle in order to enter the muscles of the tongue. The facial artery is given off above the lingual artery, and it will often run under the cover of the stylohyoid muscle and will run behind the posterior belly of the digastric muscle. It's going to quickly course deep into the substance of the submandibular gland before it reappears onto the face at the surface of the mandible. This illustration demonstrates the internal jugular vein and a number of its tributaries. Here, for example, you can see the superior thyroid vein coursing in company with the superior thyroid artery. This vein drains directly into the internal jugular vein. Also draining the thyroid gland is a middle thyroid vein, which will drain into the internal jugular vein as well. As you might recall from the thorax lectures, the inferior thyroid veins will drain into the brachiocephalic vein, instead of draining into the internal jugular vein. Here near the origin of the facial artery is the common facial vein. This vein is going to receive contributions from both the retromandibular vein here and from the facial vein coming from the surface of the face. Here at the venous angle, the internal jugular vein unites with the subclavian vein, and together they form the brachiocephalic vein. The infamous vagus nerve also runs within the carotid sheath alongside the internal jugular vein and the carotid artery. As the vagus nerve makes its journey descending through the neck, it will distribute branches to both the pharynx and the larynx. The first branch of the vagus nerve is the pharyngeal motor nerve, which will supply muscles of the pharynx. Next, the superior laryngeal nerve is given off. The superior laryngeal nerve will divide into both the internal and the external branches. The internal branch will course in company with the superior laryngeal artery to enter the inside of the larynx, whereas the external branch of the external laryngeal nerve will course inferiorly alongside the superior thyroid artery in order to innervate the cricothyroid muscle, as shown here. The internal branch of the laryngeal nerve is responsible for carrying sensory information, that is, general visceral afferent fibers, from the upper part of the larynx, the part above the vocal folds. This nerve is oftentimes considered to be the guardian of the airway. If some foreign body or liquids, for example, try to enter into the larynx, this nerve will sense that and will create a cough reflex. And also recognize that the vagus nerve gives rise to both the left and the right recurrent laryngeal nerves. The left recurrent laryngeal nerve, shown here, recurs around the arch of the aorta before it ascends in the tracheoesophageal groove on its course to the vocal folds. The right recurrent laryngeal nerve, however, is going to course around the subclavian artery, as shown here. It again will run within the tracheoesophageal groove on its ascent back to the larynx. These recurrent laryngeal nerves provide motor innervation to the intrinsic muscles of the larynx, with the exception of the cricothyroid muscle, which we now know is innervated by the external laryngeal nerve. In the image on the right, we can see very nicely the oblique line of the thyroid cartilage, shown here. Attaching from this oblique line on the anterior side is the thyrohyoid muscle, reaching up to the hyoid bone. Attaching to the posterior aspect of the oblique line is the inferior pharyngeal constrictor muscle, shown here. As a review, here is the superior laryngeal nerve dividing into the internal laryngeal nerve, which again is the guardian of the airway, and it also gives off the external laryngeal nerve, which comes down to innervate the cricothyroid muscle. From this image, we can also appreciate the left recurrent laryngeal nerve coursing in the tracheoesophageal groove. In the area of the cricothyroid joint, which is roughly in this area here indicated by the blue circle, the recurrent laryngeal nerves actually change names to become the inferior laryngeal nerves. This is a technicality. For our purposes, we'll always refer to them as the recurrent laryngeal nerves. There's no need to make the distinction between inferior and recurrent. The hypoglossal nerve is cranial nerve number 12, and it is responsible for innervating all of the intrinsic muscles of the tongue, except for the palatal-glossus muscle, which is innervated by cranial nerve number 10, the vagus nerve. Within the neck, the hypoglossal nerve loops below the posterior belly of the digastric muscle as it ascends to enter the oral cavity between the hyoglossus muscle and the mylohyoid muscle. Notice how the hypoglossal nerve slips right between the hyoglossus muscle, shown here, and the mylohyoid muscle, shown here. In the neck dissection, you won't be able to appreciate this particular relationship with the hypoglossal nerve slipping between these two muscles. However, when we dissect the oral cavity, you will find this relationship. Also recognize the close relationship between the hypoglossal nerve and the lingual artery. They often sit right next to each other, just behind the posterior belly of the digastric and the stylohyoid muscle. In the image on the right, you can now better appreciate how fibers from C1 hitchhike along the hypoglossal nerve to give off the nerve to the thyrohyoid, which innervates the thyrohyoid muscle, as well as the nerve to the geniohyoid, innervating the geniohyoid muscle. Again, these nerves are not branches of the hypoglossal nerve, but instead they are simply hitchhiking nerves from C1. Again, the hypoglossal nerve is responsible for solely innervating the muscles of the tongue, with the exception of one muscle. When you find the hypoglossal nerve during dissection, you may be able to find the muscular branch of the occipital artery. This muscular branch happens to arch right over top of the hypoglossal nerve in order to supply the posterior aspect of the sternocleidomastoid muscle. The main salivary gland of the anterior cervical triangle is the submandibular gland. This gland nearly fills the entirety of the submandibular triangle, which is bound by the mandible above and the anterior and posterior bellies of the digastric muscle below. The submandibular gland is supplied by the facial artery, and it receives its parasympathetic innervation from the facial nerve. The course and pathway of that innervation will be discussed at a later point. And to a lesser degree, the apex of the parotid gland, shown here, can also reach down into the anterior cervical triangle. The majority of the parotid gland lies over the ramus of the mandible. Just like in other areas of the body, the neck also has superficial and deep groupings of lymph nodes. These superficial nodes are arranged in regional groupings and are primarily responsible for draining the face and the scalp. These nodes will eventually drain into the deep cervical lymph nodes, and those nodes happen to be oriented longitudinally around the internal jugular vein. Of the deep grouping of cervical lymph nodes, there are two to be aware of because they are named. The first of which is the jugulo-digastric node, shown here. This node is also referred to as the tonsillar node because it's responsible for draining the tonsils. As its name suggests, the jugulo-digastric node is at the intersection of the internal jugular vein with the digastric muscle. And the second named lymph node of the deep cervical group is the jugulo-omohyoid node. Again, as its name suggests, this node is at the intersection of the internal jugular vein with the omohyoid muscle crossing over the vein. Here in the upper right image, you can better appreciate how this node is situated at that intersection between the jugular vein, the internal jugular that is, and the omohyoid muscle. From a clinical perspective, recognize that cancer at the tip of the tongue, for example, and even cancer of the lower lip, is going to metastasize and drain to the submental lymph nodes. The submental nodes are those right below the chin, and those submental nodes will subsequently drain to the deep group, which would perhaps give you an enlarged jugulo-omohyoid node. Notice there are also small lymph nodes that are referred to as submandibular nodes, here adjacent to the submandibular gland. Examiners must be careful not to confuse an enlarged submandibular gland with enlarged submandibular lymph nodes. If in fact a distinction needs to be made, the examiner can do this with manual palpation with one finger inside the floor of the oral cavity and the other hand or finger outside of the oral cavity. This can help to discern whether or not the examiner is feeling the gland versus the lymph nodes. And last but not least, the deep grouping of cervical lymph nodes is going to drain into either the left or the right jugular lymphatic trunks. These jugular trunks, shown here, will drain into either the right lymphatic duct, which enters at the right venous angle, or will drain into the thoracic duct, which enters here at the left venous angle. Here's another interesting clinical note regarding Virchow's node. Virchow's node is a supraclavicular lymph node, as shown here by the circle. While it makes common sense that this node could be enlarged as a result of head or neck cancer, what's very fascinating about this node is that it is often enlarged with either thoracic or abdominal cancer. So the point here is that just because you see an enlarged supraclavicular node does not mean you should dismiss cancer in other regions of the body. If you happen to ever see this type of enlargement of a lymph node in the supraclavicular region here, you'll first want to do a thorough head and neck exam, but then you'll want to follow that up with a thoracic and abdominal CT scan in order to rule out cancer of the abdomen or thorax. This concludes the video on the anterior cervical triangle. As always, happy studying!